So Mary was able to have a fairly straightforward intervention, but we are going to start looking at other considerations in intervention and treatment. So for our final case, just a note, this portion is going to be how it cannot go well, and then we'll see how things might go better for this patient. So Wade is a 45-year-old male with cerebral palsy, moderate intellectual disability, and major depressive disorder. He lives in a group home setting with 24-hour staffing. Wade has been wanting more and more alone time during the last month. Staff became concerned when he did not come out of his room for lunch and doesn't answer when they knock. When they open the door, Wade seems out of it. When they try to engage, he pushes them off. He's mumbling, but one of the staff members thinks he says something about wanting to die. The house manager contacts Wade's guardian, and the decision is made to take him to the emergency department for potential suicidal ideation because they're all very concerned about him. So at the hospital, the intake and nursing staff talk exclusively to those with Wade, not to Wade. The nurse begins his physical exam without telling Wade what he is doing. Wade slaps and pushes until the nurse leaves him alone. The nurse says sternly, "I'll just let the doctor do it. You're going to have to cooperate or we can't help you." The physician then enters and again does not tell Wade what she will be doing. As she starts her exam, Wade begins to yell and punches her in the face. A team rushes in and Wade is given haloperidol and lorazepam injections and is put in restraints. He continues to yell and thrash against the restraints until he receives more injections and goes to sleep. So not ideally what we want for people we care about. So some tips for professionals in emergency settings, crisis settings, or otherwise. Certainly reduce waiting times if possible. That can increase frustration. Communicate directly with the individual, no matter what their communication level is, in a calm, quiet, friendly, and positive tone. Remember that people with ID usually have better receptive than expressive language, and they will appreciate being talked to first and having their input and personhood considered. Offer food, drink, and positive distraction when that's appropriate. Allow a familiar person to be present. Definitely, we're going to look at treating the medical and biological concerns first. And then also remember that in a new environment, the problem behavior may vanish because it's a novel situation. It's still important to do a complete assessment and provide appropriate treatment or referral. So we want to avoid overcrowding people, loud and irritating noises, intimidating direct eye contact, unnecessary invasion of personal space, a direct confrontational stance, or hands concealed in pockets. So hands in your pockets might mean something different to somebody who is paranoid or anxious than it does to the rest of us. Just as an example, the picture on the left is more of a direct confrontational stance, face to face. Those two people don't look like they're in conflict, but for somebody in distress, this might be much more intimidating than the more open stance of the picture on the right. I don't love that the medical professional's arms are crossed in that picture, but he does look relaxed. And you can still make eye contact in this stance, but give somebody a little more space. So how can Wade's case go better? When Wade wakes up, he's visibly upset. He's still in restraints and he starts to pull on them. His favorite staff member is now present and goes to Wade's side, offering words of comfort, and this calms him a little bit. Shifts have changed, and Wade's new nurse enters the room. She speaks with Wade directly and in a calm voice. She asks what he needs. When he doesn't answer, she makes some offers with pauses in between. Water, crackers, juice? And Wade says juice and crackers. The nurse leaves to get these and also informs the physician. Wade's physician enters and sits beside Wade. He greets him and tells him his snacks are on the way. The physician asks how Wade is feeling, and he hesitantly answers, okay. The physician asks if he can remove the restraints and talk to Wade about what brought him in, and Wade answers yes. So the restraints are removed. With the physician sitting next to Wade and Wade's staff in full view, Wade is able to answer most of the physician's questions. The physician will speak with Wade first and then ask the staff member for clarification or for more information. It's found that Wade has been more depressed lately and he's not been sleeping well. He was very tired that morning and complains he'd been having nightmares. He tearfully says he thought he was dying in his dreams. With some anxiety for Wade, the nurse is able to obtain blood for lab work. So they're still looking for those medical biological causes for what might be going on, but nothing concerning is found. The social worker is able to coordinate with Wade's case manager to be sure an appropriate follow-up appointment is made with Wade's outpatient physician. They also do some safety planning and some safety checks, which Wade's household had already had in place. So as we move toward evaluation and ongoing treatment, we will consider both pharmacological and non-pharmacological interventions. So first, the non-pharmacological. A functional analysis can be helpful to elicit some of those predisposing, precipitating, perpetuating, and protective factors that we've discussed before, and can lead to development of interventions in various settings. Various therapies may be helpful, including occupational therapy, speech therapy, and physical therapy. Each of these therapies can give evaluation and provide or recommend needed tools or interventions. In addition to communication improvement for the individual, there may be improvements that caregivers can make in their communication to the individual, such as saying later instead of no, using first then language, or providing acceptable choices. For example, would you like an apple or some crackers with cheese for a snack? Things that allow visual aids for communication, including a picture schedule, can be very helpful. People may have anticipatory anxiety and difficulty with the concept of time, and being able to reference a schedule can be really helpful. It's also often difficult if individuals don't know a change is coming and don't have the opportunity to prepare. On the other hand, there might be a lot of anxiety in anticipating a change. So the right intervention is often very individual regarding changes. It's so important to incorporate activities that someone likes into their regular routine. We all look for rewarding experiences in our lives in which we feel joy or competence, or in which we feel cared for. Helping individuals develop and explore their interests can be an important part of intervention. As for psychotherapy, it's important to remain objective. Past experience or the interactions with the individual can change how someone decides to treat the individual. Becoming overly involved or taking the negative too personally can lead to compassion fatigue, frustration, and increased stress for the provider. This can also be true for a non-therapist provider. In psychotherapy, the non-cognitive components of treatment have been shown to be the most effective. So these are things like relaxation, self-monitoring, and skills training through role play. CBT may be helpful if maladaptive thoughts are kind of at the core of the aggressive behavior. So that's cognitive behavioral therapy. Behavioral social skills training, cognitive approaches, and group therapies have all been successful in the ID population. It is important to remember that psychotherapy could be viewed as a punishment, so it's important to make it rewarding or interesting for the individual. So we talked a little bit about general principles for medication before, but these are a few guiding principles. We're trying to avoid just adding medications. Try to discontinue a medication if you are adding one, and then deprescribe when able. So by that, I mean there is evidence that people can successfully be weaned off medication after aggression resolves. In the ID population, as well as in children, actually, we talk about starting low and going slow for dosing and changes to medication. People with ID are more likely to experience side effects and adverse events. We want to treat a specific diagnosis with the typical medications we would use for that diagnosis, and we want to treat to full remission. We also want to improve cognition or at least prevent the worsening of cognition. So we need to be careful with medications that can cause confusion or cloudiness. So to get into some of the specific medications, antipsychotics are the most commonly prescribed medications for aggression and have the most evidence for that. Risperidone, quetiapine, olanzapine, and aripiprazole have been shown to be effective. Risperidone and aripiprazole uniquely carry an FDA indication for irritability in the setting of autism spectrum disorder in children. Clozapine, which is an antipsychotic, and lithium, which is a mood stabilizer, have evidence to reduce self-injury and suicide. And there is evidence that haloperidol, which is an antipsychotic, is effective and safe, especially in emergencies. Clozapine and lithium have some really strict monitoring guidelines with blood work and lab work, so that may limit their use. Mood stabilizers are also commonly prescribed. Depakote has by far the most evidence in this class. That's an anti-epileptic medication. Carbamazepine is also an anti-epileptic medication with evidence for improvement in aggression. Lithium has been shown to be helpful, especially when it's used in addition to other medications, such as one of the antipsychotics or with an antidepressant, which we'll talk about next. In the general population, SSRIs, which are antidepressants working on serotonin receptors, have efficacy for reducing aggression. When we talked about biological risk factors, we talked about serotonin, and a lot of antidepressants act on serotonin receptors. So these might be helpful for aggression. These are also the medications we use first line to treat anxiety. So aggression that comes from anxiety might be well treated with an SSRI. Antidepressants may also help with other challenging behaviors such as stereotypic behavior, self-injury, and OCD behaviors. We do not use antidepressants in patients with bipolar disorder unless their mood is stabilized first. Antidepressants can cause manic episodes in someone with bipolar disorder. For many of the medications, we must remember that people with ID are at increased risk for seizures. And that's especially important to consider when we use medications that can also lower the seizure threshold. Bupropion is one of those that has a higher risk than some of the others. There is some mixed results for opioid antagonists such as naltrexone to treat aggression. There's some evidence for naltrexone to treat trichotillomania, which is kind of a self-injurious behavior. For benzodiazepines, these are anxiety medications. These are controlled substances and tolerance can develop. So as a patient takes them, they may need higher doses to have the same effect. And also as patients get older, benzodiazepines carry more risk for confusion and falls, but it becomes difficult to deprescribe them as patients have been on them longer. Side effects are a concern with these medications. They can cause disinhibition and a paradoxical reaction, so we want to watch out for that. But they may be appropriate in certain situations, especially when they can be used short-acting. So things like using a benzodiazepine such as lorazepam to help somebody be more comfortable getting their labs drawn. Beta blockers are blood pressure medications, and propranolol and nadolol specifically have shown some efficacy for aggression, particularly in patients with brain injury. Treating ADHD is really important when we consider aggression. Stimulants and other ADHD treatments are effective when we're treating patients with IQs above 50. They're just not as effective if IQ is below 50. The ID population does experience increased risk of tics, irritability, and dysthymia, especially with use of stimulants. So stimulants are things like Adderall as the brand name, methylphenidate is another class, so things like Concerta, Ritalin, but those are our first line and most effective treatment for ADHD. Atomoxetine is a non-stimulant medication that has been found to be safe and effective, but is not recommended as first line in this population. It's just not as effective as the stimulants are. In kids with conduct disorder, guanfacine has some evidence for reducing aggression. Clonidine has less evidence, but we use both of these regularly in treatment of ADHD. They are also non-stimulant medications. And then for aggression and behavior in general, N-acetylcysteine or NAC is an interesting consideration. The evidence base for the use of NAC in various conditions is growing, including aggression. The best evidence right now is for skin picking disorders. The evidence for use of hormonal treatment in aggression is negative, meaning we should not use hormonal agents to treat aggression. And finally, ECT may be an underutilized treatment for especially mood disorders and psychotic disorders. There is a risk because of the increased prevalence of seizures in the ID population, and you do have to be off anti-seizure medications to receive ECT, but most case reports show clinical improvement in behavioral symptoms and aggression after ECT. So it may be an important consideration if there are not contraindications to that. So these couple of slides include my references for this presentation. Thank you so much, everybody, for your participation. I really appreciate it.